Good morning to you all. Today I'm presenting delirium, also known as acute confusion, also known as acute encephalopathy. It has quite a number of names. Some people think it's psychosis, as we're going to see. So I decided to start like this to show you that delirium has a lot of associations. At the end of the day, we're going to see it's an acute confusional state, and how important it is in our profession. So my slides are not so many. It's going to be an interactive session at some point. So it's defined as a syndrome by the DSM-5, an acute onset of a fluctuating disturbance in the following cognitive functions, especially attention, environmental awareness, or perception. According to the NICE guidelines, it's known as a common clinical syndrome characterized by disturbed consciousness, cognitive function, or perception, which has an acute onset and is a fluctuating course. So from this, the most important thing is it's acute, it's fluctuating, and the major disturbance is in cognitive function. And this is really important. This is what differentiates delirium from dementia, and it's also what differentiates delirium from other psychiatric illnesses. I put the definition of this DSM-5 because elsewhere in the world, delirium is usually treated by psychiatrists, or they're the ones who are usually consulted. But since neurologists are the first people on the ground, they also need to know that delirium happens and how to approach delirium. So, and recently they're trying to change the name of delirium to acute brain failure. So if you come across the word acute brain failure, it still stands for delirium. So most centers worldwide use the DSM-5 for diagnosis. So it's important that we know it, and it has 5 things. Usually there's inattention, so the patient has reduced ability to direct or focus, or shift or sustain. Reduced awareness, that's inability to engage with interview or cognitive assessment. Unable to orient to the environment, and it's always acute. So, and there's disturbance in cognition, so this fluctuates over the course of the day. So we've had instances where we have patients, one person goes to examine and says the patient is confused, another person goes to examine and they say the patient is all right. So the fact that it's fluctuating, that's already a criteria for delirium. There's disorientation, language deficit, decreased visual spatial abilities, and perception deficit. And it's not related to the pre-existing neurocognitive deficit like dementia, Parkinson's disease, or vascular dementia. So this patient usually doesn't have already these conditions, or if they already have these conditions, this is something of a new onset and it's acute, so it fits into the criteria of delirium. So people have looked into delirium and found out that it has a number of factors that lead to delirium. So they've come up with several theories and hypotheses as to what leads to delirium. Some of them we know. At least we know how hepatic failure and alcohol withdrawal leads to delirium. We've gone through this before. But they found out that there are a number of factors, and they keep modifying it. I thought this diagram could kind of show how they're all interrelated and how they lead to acute brain failure. So far they have come up with 7 proposed neurophysiology hypotheses that try to explain this complex behavior and cognitive changes. So the first one is the neuroinflammatory process or hypothesis. So anything that leads to inflammation in the brain. So we have infections, some medications, surgical illnesses that are going to lead to the release of cytokines, which are going to disrupt the blood-brain barrier, so lead to activation of some of the transmitters like glutamate, or inhibit the cholinergics, and therefore activate the cholinergics excessively, leading to disruption in the cognitive network. We have the neuroaging hypothesis, and that's where you find that delirium is mainly found in the elderly. They say the older the one becomes, the more they are predisposed. So in the neuroaging hypothesis, they think like the older someone becomes, they cannot withstand some of the small insults like illnesses and medications. Therefore, this will still lead to the activation or inhibition of these substances, leading to neurocognitive disturbances. We have oxidative stress hypothesis, neurotransmitter deficiency hypothesis, neuroendocrine hypothesis. That's where the Cushing syndrome comes in, the glucocorticoids, the diurnal dysregulation hypothesis. This is where stress comes in. People who have inadequate sleep, especially the elderly, may become delirious. A network disconnectivity hypothesis. So all these insults may occur at the same time to a patient, or one of them may trigger the whole cascade for delirium. So studies are still being done, and maybe in the next 1-2 years we're going to have different phenotypes. And the reason this has come up is because they found that delirium doesn't only happen in the elderly, it also happens in the children, or it happens in some settings, even in anyone who's outside that age bracket. So the most common known phenotypic categorical model known is the first one, which has hyperactive, and mixed delirium. So when you find a patient, you're going to probably put them in one of these 3 subtypes. But so far others have come up from different studies, such as sedative, septic, or metabolic, such as postoperative delirium. So anesthesiologists are really trying to look into this because it happens a lot to their patients. Then there's also emergency delirium, which has come up a lot in the emergency setting because they found out it's a risk factor to high morbidity and mortality. So it's being extensively studied. ICU delirium is well known and has several studies, and this is where we find the majority of our patients. And then there's delirium in palliative care. That's at the end of terminal restless, at the end of life, which is known as terminal restlessness. Then the others are just being researched about and are being talked about. And one of them, which is so common, is delirium superimposed on dementia. So people with dementia can also get delirium, and you need to differentiate the two. So going to the subtypes.
Just go back to the pathophysiology slide. You can look at that pathophysiology when you went into 3 hypotheses. It's neurotransmitter hypothesis, the cytokine hypothesis, hypercortisol hypothesis. And when you look at that, you can see the main things here in pathophysiology is there's decrease in cholinergic pathway, increase in dopamine, you can have increase in glutamate or noradrenaline, but the other things, GABA, serotonergic pathways can be increased or decreased. So neurotransmitter pathway is actually oxidative metabolism pathway, whereby there is question to do with metabolism and insulin. That is fashion of metabolism. Then you can divide it into a cytokine hypothesis. There you are looking at one, TNF, interferon, and that affect permeability, blood-brain barrier permeability, and that can affect brain function. Chronic stress is the one associated with cortisol hypothesis, where the cortisol levels are high, possibly because of chronic stress. And then the question is, why is it more in elderly than young? What to do with brain brain function. Well, at the age, as you grow old, you don't have a lot of disturbance in brain function because of natural degeneration which has occurred, okay? As compared to the young. Delirium is seen from children to the elderly. I think you might have a slide on epidemiology. I'm not seeing this slide.
No, I do not. But at least I've mentioned it. I do not have on epidemiology. So the subtypes, the common subtypes of delirium are known. Is hyperactive delirium, which is the one that we come across the most, where the patient presents with hypervigilance, increased state of arousal, increased psychomotor activity, restlessness or agitation. Then we have the hypoactive delirium. Sorry, I didn't know this is not so. I'll change this when I'm giving out the slides. Hypoactive delirium is also common, but it's usually missed by us, the medical workers, because the patient is usually withdrawn, lethargic, has decreased psychomotor activity, decreased responsiveness, and apathy. We've had several patients like this, and you think it's just that they are quiet or something, until maybe they switch over to the hyperactive state, and or they fall under the mixed motor type, where there wax and wane, and that's when we notice that probably the patient is delirious. So it's very important to note that patients who are on this age of the hypoactive delirium can actually be the dangerous patients, because you may miss out the most, you may miss out and they go into coma. I think we had a patient who used to be admitted under Dr. Mativo. He used to come in very mute, if you remember him. So he used to usually have hypoactive delirium. So it's something that we can miss very easily. So I summarized the causes and the triggers into these mnemonics. I watch death. It's one of the most common mnemonics. I watch death, which has things that can trigger or can cause delirium, or delirium is painful, whichever you decide to use to remember when you look at a patient. So in I watch death, we have infection. So any infection can predispose to delirium. We have the most common are the UTIs and pneumonia, but we also have in our setting HIV and sepsis. Withdrawal. We've seen so many patients who come in with alcohol and they have withdrawal or sedative hypnotics. Then we have the acute metabolic. So patients who come in with electrolyte derangements usually are delirious. So we have acidosis, alkalosis, renal failure, hepatic failure. I think we've seen this, or we even have examples right now in the ward. Trauma as well, head injury, or in the postoperative state, or hypo and hypothermia, burns, CNS pathology. So we've seen people come in with cerebrovascular accidents and probably they come in delirious. We do MRIs or CT scans when we find they've had a stroke, or with tumors, with seizures, with hemorrhage, hypoxia, deficiencies, vitamin B12, thiamine, folate, endocrinopathies, hypothyroidism, parathyroid disorders, acute vascular, where we have hypertensive emergencies or hemorrhages, toxin drugs, which is really common. So alcohol comes here at the same time, and then also our own drugs that we give on the ward, like the opioids, can predispose patients to delirium, especially the elderly, and then the heavy metals. So on the other side, delirium is painful. It's still the same thing. It's only that in delirium is painful, they mix both the contributing factors with the causative agents, and some of these things go hand in hand. Like in the elderly, dehydration is a major cause of delirium. So in delirium is painful, at least the youth under hydration. So you're going to have to really assess the patient. Is the patient adequately hydrated, or are they not? Are they malnourished? It's a contributor, and it also can cause delirium, especially in ICU settings where if there's no proper nutritional follow-up, and these patients are also affected by drugs that can cause protein binding, you might find that this is leading to delirium. In the elderly, lights and noises, different change in environment can trigger delirium. So as I proceed, came across something of how to induce delirium in our patients. Well, maybe how to diagnose is what I meant. But they found out that hospital settings, as health workers, we have a very big contribution to delirium, how we treat the patients, especially the elderly. They've come to a new environment and we may miss out key things. So in this picture, it's really important. You can see like one of them is like this old gentleman. You can just look at his state. This one seems to be okay. I don't know if you can see it. He seems to be a little bit hyperactive. This one seems to be knocked out. So it really happens. It really happens a lot. We're going to see how we play a big role in this. So in the diagnosis of delirium, the first and foremost thing is to carry out a clinical assessment. You can base it on the DSM-5, or we have some, can I call them assessment methods that have come up. The most common one is the confusion assessment method. It's been changed to the short CAM or the CAM ICU if it's in the critical care or in the recovery room. And then if a patient comes from home and they seem to have delirium, a good history is very important. And if you suspect or if you know this patient has dementia, it's always better to treat for delirium first because it's an acute state and it's reversible. So the confusion assessment method CAM has four parameters. The first one is acute onset and fluctuating course. This one is obtained from a family member or from the caretaker or from the nurse, and it's just to get to know if there is a change in the baseline. As I explained in the beginning, one person will come assess the patient, they are confused, the next person might find them fine. So if you go to assess a patient and the nurse tells you this patient was confused at a certain point, and as much as you feel they seem to be not confused at this point, you need to take it serious. That's already a point. And fluctuation is one of the criteria. So there are two questions you ask. Is there evidence of an acute change in mental status from the baseline? If it's present, that's already a yes for one. Or did the abdominal behavior fluctuate during the day? That is, it comes and goes, or it increases or decreases in severity. Then inattention. So did the patient have difficulty focusing attention, for example, being easily distracted or having difficulty keep tracking of what is being said? Disorganized thinking, shown by positive response to the following. Was the patient's thinking disorganized or incoherent, such as rambling, irrelevant conversation, unclear or illogical flow? And then lastly, altered level of consciousness. So here you need to know at one point were they normal alert or hyper alert or drowsy or difficult to arouse. So the diagnosis is basically features of 1 and 2 or either with either 3 or 4. As long as 1 and 2 are present, the patient is delirious. So delirium, the differential diagnosis of delirium is usually dementia, so it's good to differentiate between the two. So the symptoms, age of onset. Delirium can happen at any age, but the most common ages are below 12. There's pediatric delirium, and above the age of 40. Though in some places they say it's above the age of 65. Then dementia is usually in the elderly. You will not find it in someone less than 50, usually. Then acute onset, and the other is gradual and insidious. And then symptom course, rapid, fluctuating, the other is stable and progressive. So duration delirium is usually days to weeks, though sometimes it may happen up to months if this patient has multiple triggers and factors that are contributing to delirium. And delirium is always reversible. Then the history is really important. The medical history is important. Substance use, medical illness, trauma, as we looked at the causes and the contributing factors. Involuntary activity in delirium, I think we've seen patients with tremors, hysteresis, or who are stuporous, who are drowsy. So in dementia, unless they have some of these involuntary activities, usually that's not present. Then the affect in delirium is usually emotion and labile. Orientation is usually impaired, attention is impaired, hallucinations may be present. Then the speech is usually incoherent. And then consciousness is decreased to impaired. And intellectual function is usually impaired for both. So it's good to differentiate that too. So recently, about a year or two, found out that there are misconceptions about delirium, especially among the health workers. It's not taken seriously. So the first misconception is this patient is oriented to person, place, and time. I think we had a patient like that last week. One of us went, the patient was oriented to place and time, another person went and they weren't oriented. So now the argument was, are they delirious or not? Being oriented in person, place, and time does not mean that they're not delirious, actually. So you need to evaluate the attention and orientation and memory, or you should get a history from the nursing team or the family member to see if they are altered, there are fluctuations in the mental status before you can prove this person is not delirious. Then delirium always resolves. So at times it may persist for days and months, especially in patients who have other comorbid conditions like diabetes, hypertension, or end-stage renal disease. So they may wax and wane as long as they have the insult still going on. So for example, a patient with end-stage renal disease, as long as if they're not having adequate dialysis, it means they're going to keep waxing and waning until you control their metabolic disturbances. A patient who has diabetes mellitus, if they have poorly controlled sugars, they might keep waxing and waning out of delirium for months or even up to years. So it's something to keep at the back of our mind. We should expect frail older patients to get confused at times, especially after receiving pain medication. It's not always true that they should always get delirious after pain medication. They might have other factors contributing to the confusion, so you need to do a further assessment. The goal of a delirium workup is to find a main cause of delirium. Delirium is always multifactorial. It might have 3 or more causes, and you need to sort each one of them. New onset psychotic symptoms in late life likely represents primary mental illness. That's not true. New onset psychosis might be delirium, and you need to find the cause and treat the cause. Delirium in patients with dementia is less important because these patients are already confused at baseline. These patients are actually at risk. Delirium has a high mortality and morbidity. Several studies have been done. So if a patient who's demented has a new onset change from the baseline, you need to find out what it is and treat it. Delirium treatment should include psychotropic medication. This is not true, especially in the elderly. The patient should be thoroughly assessed. First, remove the triggers or the causative agent before you can consider a psychotropic drug, because some of these psychotropic drugs can actually worsen the delirium. The patient is delirious due to a psychiatric cause. I think I've kind of hinted on this already. And it's often best to let quiet patients rest first. As we've seen, we have hypoactive delirium, and such patients, if you don't monitor, you can actually end up losing them. Patients become delirious just from being in the intensive care unit. It's not necessarily. We have so many patients on the ward who are actually delirious, who are not in the ICU. However, in the intensive care unit, it's been shown that they're delirious due to the pharmacological agents they're receiving and physiological and the nature of the ICU settings. So settings elsewhere in the ICUs, they're starting to change their environments. You find they're playing music for these patients. They encourage families to visit such that they can reduce the onset of delirium. So when you suspect delirium, there are some investigations you can do. Different settings have come up with different investigations that can be done, but it's always good to start with the baseline investigations, the initial screening tests. That's just to carry out the electrolytes, the full blood count, liver, thyroid, glucose, C-reactive protein to find out why, urinalysis, chest X-ray, CT brain. HIV should also be one of the initial screens in our setting, though in this slide it's coming to the second line investigations. And then if it's unclear or you cannot find a cause from those initial screening tests, then it's good to go to the second line investigations. So that means you now look further. What could it be depending on your age, on the age of the patient? So you're going to look for other things. Is this an autoimmune cause? Is there something in the CSF? So you're going to do CSF studies, then CT scan brain to rule out the strokes, the hemorrhages, MRI brain, then the EEG to rule out seizures. And then third line investigations, should you still be stuck, now look, hunt everywhere. So do further studies, CT chest, abdomen, ultrasound as need be. And if the worst comes to the worst and you don't have a diagnosis, then you can look into doing a brain biopsy. But usually in our setting, by the time we're done with the initial screening test, at least we found out a trigger or an insult that has predisposed to delirium. For that matter, now it's time for me to stop talking. So we have question 1. Kuka, you're going to lead us through question 1. Mini-mental state exam in delirium is not advised. Studies have shown it has no benefit. This patient has an acute confusion, so most likely it's not going to help in diagnosis. So I tried to avoid it in the presentation.
Because of fluctuation.
Yes.
Okay. Sometimes the immunity is going to fluctuate. That's against dementia, which is a progressive, which you can monitor. But for acute case issues, you can't, because sometimes they fluctuate. So it's not important to know when to state it in this patient.
Okay.
So it is one test that you would do cognitively to assess the patient in this kind of situation. Apart from the questions, here I can add so a digit span is a good test. Because a digit span is a test of attention. It helps you to, so it's really, attention is equal to kind of working memory, yeah? So what you immediate recall, yeah? So that's a good test too. So if somebody's digit span is low, I mean that's probably the only major cognitive test you could. And there are some scoring systems on CPI, but it doesn't really matter in the clinical practice.
So, okay, thank you for the input.
So it's a 50-year-old man who's admitted for an elective laparoscopic facial nephrectomy, renal tumor. He has a history of depression resistant to treatment and an insulin-dependent diabetes mellitus. On the first day post-op, he became agitated, thought that he was going to be attacked by the nurses, and described seeing spiders in his bed. He was treated with morphine-based pain relief medications, antibiotics, and his usual antidepressants. On examination, his pulse was 89, the blood pressure was 152/93, and his temperature was 37.0. There have no abnormalities apart from evidence of the surgery.
Okay, so what do you think from the discussion we've had?
So so he's becoming agitated within one day post-op, and then he also has evidence of perceptual disturbance, seeing spiders on his bed, as well as delusions thinking he's being attacked by the nurses. So from the DSM criteria, one, there's no from the history, there's no evidence of whether it's fluctuating or not, but the onset of the symptoms are within a few hours or days. There seems to be perceptual disturbances. And then he has predisposing factors for developing the confusion state. One, you said being in hospital, number two, the medication that is on, the opioids, as well as previous history of depression. So I think this will classify as delirium.
Okay. So the only investigation that was available, unfortunately for us, was CRP. So what's the most likely cause of his presentation? So Kuka, you'll not answer. Maybe Fazal, what do you think is the cause for his presentation? We have...
CRP protein is slightly elevated.
Yes. So does everyone agree? Yes. So
just in this case, if a patient has a lot of hallucinations which are animal, they tend to be drugged. When a patient tells you I'm seeing this, I'm seeing this animal, they tend to be drug-related hallucinations. Therefore, that would be very high. So the hallucinations are often animals, spiders, drug-related issues.
Okay, but in this case, he has multiple factors.
So did he get medication?
An alcohol history, whether he was alcoholic, prior intake.
Okay. Okay, so yes, the answer is A. So we should always remember delirium has 3 or 4 significant factors per case. So what you may see as one cause, maybe a UTI or maybe one drug, you might find you have so many other things right under. So, and that plays a role. So don't forget, you might just be seeing the tip of the iceberg. Question 2. Antonina, take us through.
The 20-year-old man was admitted to jumping from the first floor below. He fired at but there was no evidence of head injury. However, his consciousness level died. Super alternating with extreme agitation. He tried to remove his IV, saying that they were snakes. His family reported that in the past he had talked to suicide and had been using drugs.
Okay, so what do you think?
Delirium.
Okay.
Withdrawal, maybe drug or
Another is
okay.
that's your idea.
So his limb saving surgery, and then his consciousness has been varying between super and agitation. And then he's having hallucinations. There's a significant history of drug use in the past. I'm trying to commit suicide.
Why did you jump from the first floor window?
Yes. Okay, so let's proceed to. Someone seems to have a question. I proceed. So, Karishma, maybe you're going to tell us what's the most appropriate next step to manage his presentation? Consider antipsychotics, give benzodiazepines, give pain relief medication, keep sedated with input from an anesthetist, give no medication but observe. Okay, do you all agree? She said give antipsychotics.
Give any type of observe. What kind of hallucination do the individual?
Snakes.
So snakes with a history of bad use points towards some withdrawal problem. Predominantly it could be opiate, but most likely taking alcohol is 20.
Yes.
We don't know why he jumped. He's depressed. History of issues. So depressed people usually have a high prevalence of substance use. So I think putting together most likely presentation would be alcohol and alcoholic hallucinosis.
I would say that the thing to learn from this patient, from what you were saying, is there are many factors. So one is he's fallen from a first floor window. should have had a head injury. Yeah. Okay. So trauma is one thing to always think about in this patient, isn't it? Secondly, actually, they don't say that he's post-op. So this seems to be in a pre-op situation. He's being taken for surgery, and before that, from the rubric. Is that correct? Yeah. He's post-op.
He's also post-op.
But he's post-op.
Yes. He required.
Okay.
Yes.
And then obviously the drugs. And then, I mean, he may have been on, so he's had a history of depression, but he may also have been on antidepressants or, other medications apart from alcohol and other recreational drugs. He may have been on other medications. So we really don't have the full picture. So in it would be sepsis even at that point, so that they would be kind of multiple factors in this situation. Okay? But clearly, I mean, one major player would be the drug that you say here.
Yes.
Maybe we can.
It's mixed.
So that the hypoactive is mixed.
And then the extreme agitation.
Yeah, so it's more of a mixed picture. So, as Karishma has put it right, and basing on all our discussions, A is correct, consider antipsychotics. Yes, this patient has been depressed in the past, has tried to commit suicide. They could be drug withdrawal, so the management here is actually antipsychotics.
But what happened
Because
is
alcohol. Because alcohol, we don't know which drugs.
But he has signs of psychosis.
Unless you say that he has
Psychosis.
mood disorder with psychotic symptoms.
Yes.
But in this case, I don't think, based on this information alone, the best choice. I mean, we have agreed that it's multifactorial, so you just have to keep asking yourself, thinking of the box of what are the things that will explain this. I don't think this.
It's a visual hallucination. But you see, something prompted him to jump out, right? So I agree, we need more history.
Yes, but
It's not something that started post-op. It's something that's predisposed him to jump out of the window from the very beginning. So yes, he could.
Depression, why giving him?
What if he got a hallucination and that's what prompted him to do it? We don't know. So he could be having an underlying psychiatric issue. So he could be.
We don't know.
I think we're using a very better history.
Yes.
The thing is, we need
But you can't
to
keep
examine
him
the
without
patient and get
medication.
a better history than that. That is
Ethics, you get a better history.
So it's not one of the options.
To be fair, you would consider, it doesn't say you, but you would consider.
that.
I'll tell you why. Because this guy is trying to pull out his lines, he's probably maybe critically ill at that point, when you need a line. I mean, the first thing you need to do is to get control of the situation. You can fluff around after that and think about what is causing the delirium, yeah? But I mean, really, faced with that patient, what would you do? You have to get control of the situation. So if you can,
the short-acting benzodiazepine also give better control.
that's a very good point. It can, but there is evidence that use of benzodiazepines in delirium simply worsens it. Yeah. It is used, I know, I agree with you, and we do use it. Sometimes we have no choice, sometimes we want to avoid antipsychotics as much as possible, like in neurological patients, at times when we avoid. But an antipsychotic might give you control without too much sedation, especially if it's a small dose. And this neurological patient, this neurosurgical patient, I mean, even though there was no immediate history of that injury, the truth of the matter, he could develop an extradural or subdural, and maybe this is the presentation. You don't want him too upturned, and you would. I would agree. I would consider. I may not give it, but I would consider.
Yeah. So, question 3. Diana, you need to take us.
A 70-year-old man was admitted following a fall in his flat.
Everybody seems to be falling.
He was found to have a fluctuating mental state with inattention and agitated behavior. He lived alone and there was a history of excessive alcohol use and falls, but no previous history of confusion. Investigation, a CT scan of the head showed some small vessel disease. What is the most appropriate next step to evaluate his mental state?
So yesterday we went through cognitive higher function cognitive tests. So yeah, here we have the Eden-Brooks clock drawing test, confusion assessment method, informant questionnaire, mini mental state examination. So what's the answer?
C.
Yeah. Yes, so the answer is C, confusion assessment method. So we already know why a mini mental state examination is not going to be useful. Eden-Brooks in this case is not going to, it's not one of the tests we do for delirium.
It's a long and detailed cognitive exam. The last thing you want is to subject yourself and the patient to that. Seriously, you will be crying by the time you finish.
Clock drawing test might not help you in making a diagnosis. Informant questionnaire. This is especially helpful in dementia. So we'll now come to management. In the management of delirium, prevention is key a lot, especially in the elderly. So the first thing, when you admit this patient, you want to have, they're all interrelated, as you can see. So when you admit a patient, especially the elderly or one you think may be predisposed to delirium, you want to avoid or remove medications that may trigger them into delirium, and benzodiazepines are one of them. Opioids and antihistamines, especially in the elderly. You want to use them in caution. Then reorientation. Probably these people have been in their homes and they have particular clocks, calendars, or they have some reminders. You want to maintain that. And for those who have issues with their eyesight and hearing, you want to use hearing aids and glasses. So if an elderly person is used to using their glasses, don't tell them to take them at home. Tell them to keep them at the bedside so that they can use them. You know, lack of sight might be the beginning of hallucinations and perceptual disturbances. Prevent emotional distress. Then you want to normalize the sleep. So you're going to avoid late night medication for these patients or vital checks for these patients, because you're disturbing their sleep-wake cycle, and that can predispose them to delirium. Then try to mobilize early. Try to treat all the ongoing conditions and make sure there is no electrolyte imbalances and pain is adequately treated. So all these can avoid delirium, or we can prevent delirium before it happens. Okay. So in the management, identify the causes, contributory, maintaining factors, manage the cause. So managing the cause, I think we've gone through it. Communicate with the primary team. So in this case, if the patient is in ICU, for example, and is very delirious, you need to tell the primary team your patient actually has delirium. It's important because the primary team might be making decisions that are actually tipping the patient over to delirium. So they'll become more careful. Educate the family about the condition, nature, symptoms, their role in management. And then monitor the patient's clinical status. So you need to educate the family, and their role is really vital because in the elderly, it's good for them to see someone they're used to daily. So you actually encourage the family to keep doing visits such that they can actually reduce the symptoms of delirium. Then the non-pharmacological measures, which we're going to go through, are many from head to toe. This includes adequate diet, nutrition, eye care, bed care, pharmacological agents. We'll go through and when to consider them. So, principal use of antipsychotics. So, in some studies, they've shown that antipsychotics are not so beneficial in delirium, while other studies have shown that antipsychotics may be of some use. So, the first thing you want to do is to weigh the benefit and risks of using them. So, does this patient need an antipsychotic? That's number one. And then, depending on the age of the patient, you want to make sure they are safe for the patient. So, in the elderly, you'd want to have a baseline ECG and to evaluate the QT interval. Then you clearly document the indication for starting that medication. So, for example, you say extreme agitation in the file or on the T-sheet. And then you use the lowest effective dose. Then from the lowest effective dose, you start titrating upward if the patient is not improving, and then you monitor the symptoms of delirium. As soon as patient is out of delirium, you'd want to wean them off these antipsychotics. Then you monitor for the side effects, oversedation, extrapyramidal side effects, and then in general, for patients with hypoactive delirium, you want to avoid antipsychotics as much as possible. So, the antipsychotics used, I put there a table. The most common in our setting is haloperidol. I think we've had instances where we've had to use it for patients. So, the lowest effective dose is 0.5 milligrams, and the maximum dose you can give is 20. But you want to start with the smallest dose and you keep titrating, and perhaps maintain them on that.
Lower than like 0.25, and maybe some of the recommendations that we use, like 0.25 milligrams, and then titrate upwards, especially if you're using it IV. And can I just make one point that, like you said, you kind of document in your, you think through and document in your notes the reason you're using it, and so you're not using the antipsychotic for delirium per se, because the patient can be delirious, but so long as they are safe, you can now look for the causes and sort them out, but if a patient is delirious, is a danger to themselves or to other people, then obviously you need to take control of the situation. That's when you are using the antipsychotic. Even though trials are generally not in favor of them, so the most recent studies, there's been a study published last year in December in the New England Journal comparing haloperidol to ziprasidone to placebo, and there was really no benefit in that study. But in spite of that, you can use them. But always remember, you're not treating delirium per se, but you're treating a particular situation, a particular symptom that is getting out of hand.
Very traditional is the best. I think people try to argue, but most of us will start with
Okay.
the other thinking with haloperidol, looking at the antipsychotics, what's the mechanism of action of antipsychotics? Yes, because one of the pathophysiology is excess of it. And therefore, that is completely, that's one of the theories coming out of the drugs, the ones that have been studied. But as like I said, there's a lot of controversy about giving resistance. But out of agitation, you just need to pack the patient. But most studies are negative.
And benzodiazepines are reserved for?
This is a question.
I have a question. Antipsychotics lower the seizure threshold. So, why would you give it to a patient with alcohol withdrawal? The other patient?
The other patient, we don't have history of alcohol.
And do they lower the seizure threshold?
Yes, they do. So, as you look at this chart, what you're going to give in alcohol withdrawal are the benzodiazepines. So you're not going to give the benzodiazepines to other patients who actually have delirium and no history of alcohol. So that's why history is very important.
The other thing is, in epilepsy, you don't preempt seizures. You can't preempt a seizure in any patient. There are very few guidelines to say you must prevent a seizure occurring. That is only in SFA where there's a fear, but usually there is no way you can preempt a patient with a seizure. Unless a seizure has occurred, now that's when the physicians change it. You can't see you and say, no, this one will get a seizure. It's nothing. No marker will use to decide. It's only investigation.
I think to answer your question, the psychotics and the seizure question. But then, sometimes we have things that, antibiotics do as well, but then there's
the patient with movement disorder, like Parkinson's, Delirium, how safe is that?
Yeah, so we generally want to avoid dopamine antagonists completely in that situation. And sometimes in that situation you could consider benzodiazepine if you're really stuck. The other thing to consider is drugs that are thought to be less like, so there's a drug called clozapine, which is the safest to use in people with Parkinson's. And then perhaps the next safest is Cochard. But if I remember correctly, both of these are available as oral agents. But if you have a really hard situation, you can use a small dose of hepatitis just to control things and then move on to other strategies. If you really stuck.
But you can use a typical antipsychotic to remove. But Bujalpine has a lot of evidence, it's more safe, the safest.
So it's kind of mild action and it's very low doses. If they get to maybe the balance without wasting the Parkinson's.
Okay. Non-pharmacological management is also what's used for prevention, and I think we've gone through it already. Nutritional fluid replacement, sleep enhancement, and all that. So in summary, I thought this would be very important. Delirium, we've looked at it, it's an acute confusional state. We've looked at the criteria, and then not to forget to take a good history and not to forget that it's multifactorial. So if you know a patient has delirium, you're going to have to go through the supportive measures, maintain hydration, avoid restraints, mobilize patient, orientation, then review the medications, perform focused history, physical examination, and do the necessary tests. So if you have an offending drug, you can discontinue it and then see if it improves the patient. You have trauma or a focal finding, find out what it is exactly and focus on it. You have an infection, focus on that, begin the appropriate antibiotic. Unexplained fever or rigidity, perform a lumbar puncture, no obvious etiology, look wherever you can find it, and then if patient improves, discharge according to the appropriate setting or continue the appropriate management. If the patient doesn't improve, reassess and consider the prolonged delirium syndromes, or look for the triggering factors. On this other side, as you've instituted the supportive measures, if the behavior interferes with the care and safety of the patient or for the people around them, then you're going to consider an antipsychotic, as we've seen. If it does not, then continue evaluating and treating according to the causative agents that you find. So these are my references. Thank you so much. I would like comments and to hear more from you.
And I just said it was very well done. Just to make another point, one thing not to forget in our setup also is Wernicke's. Wernicke's encephalopathy is something we actually don't pick up sometimes. And it's good to think about it and think of preventing it and not treating it. So in a delirious patient, So I'll give you an example. In private clinic, I was once called to see a patient post severe malaria, renal failure, on dialysis. He just kind of come off dialysis now because his renal function was improving. Other previously well, and he was. I was called because they thought he had an acute stroke. Yeah. So he was fine, and then one day in the morning when his wife came, he couldn't spell, he couldn't tell his daughter's names, and he couldn't write. So it was a bit atypical, his presentation, so it was quite, it was important to think about his stroke. He was scanned, his scan was normal. Believe me, the whole thing disappeared with timing. So just giving high dose timing, so if you're treating Wernicke's, then you need to give really high dose timing. So you need to give about 500 milligrams 3 times a day for at least 3 to 5 days, and then step down to about 500 milligrams per day, and continue that for about 10 days or so. So if you're doing that, and then replace timing for longer for about a month. If you're doing that, so if the time that's available here is in Fabrinex, isn't it?
Yeah.
So Fabrinex has 250 milligrams in 1 vial. So if you've seen my prescriptions for Fabrinex, there are 2 vials each, 3 times a day. So that gives you the 1500 milligrams that you need per day. If you're treating, if you're trying to prevent, then you can aim at around 500 milligrams per day. Yeah, that would be adequate. So that's one thing not to forget. You cannot, and this patient had no alcohol history, so it's not necessary that the patient has to have an alcohol problem. But certainly in the situation of alcohol, you need to, especially as you deal with clinics. So when it is associated with sepsis, with dialysis, renal failure, undernutrition, as well as alcohol.
Nutrition in any cerebral signs?
It was a little bit ataxic on walking, just very bad, very bad. Yeah. Everything else was fine. I moved. So you can get, it's like an atypical, presentation.
Thank you, Dr. Huka. Thank you, Dr. Mativo. It looks like there are no questions. So I think we now know how to diagnose delirium and to look out for it. And I'm sure we all could reflect on some of the patients we've come across and didn't think or missed out on the diagnosis. Thank you.